Hi, my name is Robert West and I'm Professor of Health Psychology at University College London, and I head up a team of researchers which aims to find better ways of helping people to stop smoking and to get people to use those better ways of stopping smoking. This is my declaration of interest. I undertake research and consultancy for companies that develop and manufacture smoking cessation medications, including obviously Pfizer, but also Johnson & Johnson and GSK. And I'm an unpaid advisor to the UK Centre for Smoking Cessation and Training, which delivers materials, resources and training for the network of stop smoking services around the UK and in fact in other countries as well. And Cancer Research UK, a major medical charity, funds my salary and much of my team. What I want to do in this presentation is to provide you with just top-line information and my own particular take on it regarding key research findings to support your discussion or the discussion of your colleagues with stakeholders, funders, health professionals of one sort or another and policymakers to try to bridge this enormous gap between what's effective in smoking cessation and what people actually use. And obviously we have particular experience in the UK around trying to increase the rate at which people use effective treatments to help them stop smoking. But even there, as many of you will know, it's quite a struggle. And then to use these new findings to promote the provision of cessation support to help with the discussion that one might have with these key stakeholders. I'm going to start by top-line findings of the EAGLE study, which obviously is top of mind at the moment and has been, I think, and will continue to be increasingly influential in healthcare decision-makers' behaviour. And I'm going to just go through what the EAGLE study is, what the findings were, and what I think it means in terms of how we can move forward with key stakeholders. So, as you know, probably many of you, that the EAGLE study was a study primarily focusing on the neuropsychiatric safety of varenicline, but it also looked at efficacy, comparing nicotine patch with and placebo with both varenicline and bupropion, and it arose out of concerns that the FDA and the EMA had around varenicline and bupropion safety. We'll come to that in a minute. Okay, so the overview of the EAGLE's design and methods. It was a multi-centre, triple dummy, double-blind randomised controlled trial with equal allocation to groups. Triple dummy because it's involved different types of medication, including a nicotine transdermal patch. And the treatments compared, as you'll no doubt be aware, were varenicline, bupropion, nicotine transdermal patch and placebo. It was the largest trial of its kind ever conducted and probably ever likely to be, given the resources and the logistic difficulties doing a study of this kind. But it contained around 4,000 non-psychiatric smokers who wanted help with stopping smoking, and around 4,000 people with a psychiatric history or current psychiatric disorder. The primary outcome was a composite of a range of neuropsychiatric adverse events, and I'll show you the list in a minute in case you're not aware of it. But it's a very comprehensive range of neuropsychiatric adverse events. The secondary safety outcome was specific adverse events, as well as any serious adverse event as conventionally defined, for example, in terms of hospitalisation, death, or other things needing treatment in hospital and so on. So we also measured, using standardised scales, measures of suicidality and of mood, because these were areas of particular concern to the regulators. And in terms of efficacy, the primary outcome was continuous abstinence through weeks 9, 20 to 12, but there was a secondary outcome which was 9 to 24, and personally I always use 9 to 24 as my headline figures, because the evidence is that it's a good idea to look at abstinence over a longer sustained period in order to be able to predict abstinence later on, which is what we need. We need to predict it out to end of life. So I mentioned earlier why the study was conducted. The US Food and Drug Administration and the European Medicines Agency were concerned about neuropsychiatric safety as a result of spontaneous reports that were coming from users and from relatives and people who knew users. Now, of course, the thing about those spontaneous reports is that you have no baseline to compare them with, and you really just don't know what the provenance of those reports are. But they were sufficiently frequent and they were sufficiently serious for the drug regulators to put a warning on varenicline and to mandate Pfizer and GSK to conduct this large randomized controlled trial which involved both varenicline and bupropion. Interestingly, this was the case even though meta-analysis of previous randomized trials and large observational studies which did have comparisons, comparative groups, usually NRT, hadn't found any evidence at all of an increased risk in neuropsychiatric adverse events. But the FDA and particularly judged that that wasn't enough to provide reassurance. And even though a succession of such studies have continued to be done and reviews continue to be undertaken with exactly the same results, they still felt that the EAGLE study would be required. Moving on to the results. Well, I'm sure many of you are familiar with the top-line results with regards to safety. So this is the prevalence of any designated adverse event within the composite outcome measure that had been defined. And interestingly, and perhaps a little surprisingly, what we saw was that with regard to varenicline versus placebo, actually varenicline showed a lower rate of these events than did the placebo. Bupropion showed a similar rate and NRT showed a similar rate. And the 95% confidence intervals, which you can see on this graph, were actually, in the case of varenicline, not spanning 0 for the risk difference, which is to say that if this were any other kind of study, an efficacy study, for example, you might say that there was a significant difference. When it came to the psychiatric cohort, the picture was somewhat different. There was no significant differences between any of the groups, varenicline versus placebo, bupropion versus placebo, and NRT versus placebo, but you can see that both varenicline and bupropion showed slightly higher rates of adverse events than did the placebo, even though this didn't reach statistical significance. And the interaction between the cohort, that's the non-psychiatric versus psychiatric, and the treatment condition met the criteria that had been preset, which was a p-value of 0.1, for analysing these data separately. So the question then becomes, with regard to the psychiatric cohort, is there anything going on that we need to concern ourselves around? Even though the result wasn't statistically significant, perhaps there's enough of a signal there to make us think, well, maybe there is a pattern which we can observe. So what I'm showing here are the individual symptom data in the psychiatric cohort only. And if you look down the list, starting with anxiety, depression, feeling abnormal, hostility and so on, I think you probably agree that it's quite hard to see any particular pattern. It's not like the symptoms are all clustered in a particular group, which rather suggests, or at least it does to me, that this is more of a random patterning than it is showing something, a clear process which is being caused by varenicline. Perhaps the only one that you might think as an exception to this would be aggression, with varenicline showing 14 cases. Remember, this is 14 cases out of out of 2,000 people versus 8 cases, but that's 6 cases over 2,000 people. So I think you'd be hard put to say that there was anything much going on. What was also interesting, I thought, was that one of the FDA's concerns was that people would feel quite weird symptoms, nuanced symptoms that didn't really fit very well with the standard criteria, and we sought very hard to try to capture these. So we had, for example, one in there which was just feeling abnormal, which should capture those. And what you see is that even in the psychiatric cohort, that just didn't show up at all. Neither did hostility, where there were 0 cases. So I think that from that it gives us some confidence that that non-significant difference between varenicline and a placebo is probably not reflecting a causal pattern. But let's look at the other key secondary outcome measures in the psychiatric cohort only. And what I'm showing on this graph are the severe adverse events. These are adverse events which are judged by the clinician to have a sufficient level of severity. It's quite a subjective judgment to be considered severe, and serious adverse events, which has a very specific definition, which involves, as I mentioned earlier, hospitalization, for example, increasing the length of stay of a hospitalization, death, and so on. So serious adverse events is the one that we're really going to be very concerned about. And again, you look at the figures, and with the severe adverse events, you see absolutely no difference whatsoever between the 4 groups. In the serious adverse events, the rates are extremely low. Remember, this is numbers out of 2,000 people, and in the placebo you've got 3, in varenicline you've got 6, and in bupropion you've got 5. So again, not really any hint that there's anything major going on here which is attributable to varenicline. So how would that lead me to express the key safety findings of this particular study? And I've put on the slide here the form of words that I would typically use talking to a clinician or someone who was concerned about safety. So I would say that with regard to patients or smokers without a current or past history of psychiatric disorder, varenicline and bupropion almost certainly do not increase the risk of neuropsychiatric adverse events, and varenicline may indeed reduce the risk. That's what the results of this study are telling us. Can't rule it out completely, because you can't rule anything out completely, but I think almost certainly is the word that would cover it. With regard to smokers with current or past psychiatric disorder, it's a little different, but this is what I would say. Varenicline and bupropion may increase the risk of neuropsychiatric adverse events, but the evidence is inconclusive. Any increased risk appears to be limited to events of mild to moderate severity, and they follow no clear pattern of symptoms, and they do not include feeling abnormal, depressed, paranoia, or suicidal behaviour, which are key areas of concern for the drug regulators. If we turn now to the efficacy results, as I've mentioned before, my own interest is primarily in longer term efficacy. So if I direct your attention to the right hand side of the slide, you can see that for the overall study cohort, that varenicline was producing 9 to 12 week continuous biochemically verified abstinence rates of 21.8% compared with 9.4% in placebo, 15.7% in nicotine replacement therapy, and 16.2% on bupropion. And in fact, as you can see probably quite clearly from this graph, the relative success rates or abstinence rates in the different drug conditions are the same in the psychiatric and the non-psychiatric cohorts, although the psychiatric cohort has a slightly lower overall success rate. Cochrane had already done a network meta-analysis of these comparisons, but they lacked direct comparisons between, for example, varenicline and nicotine replacement therapy. although as you'll be aware there were good comparisons already between varenicline and placebo. And what you see with the orange triangles there is where Eagle's trial compares with the findings from the network meta-analysis. And I think it's a testimony to the potential value of network meta-analysis that they got it almost spot on. The Eagle's trial matches up very, very closely with the estimates provided by the network meta-analysis. So we can have a high degree of confidence that these estimates are pretty close to the mark. So how would I express the key efficacy findings to stakeholders, clinicians, policymakers and funders? I would say that varenicline improves smoking cessation rates compared with placebo, but also compared with bupropion and nicotine transdermal patch. And that bupropion and nicotine transdermal patch improve smoking cessation rates compared with placebo. And very importantly, especially as increasingly more and more of people who are still smoking have either current or past psychiatric disorder, the effect is proportionally similar for smokers with and without that psychiatric disorder. That's really important. So the key message from the Eagles trial for smokers and service providers and policymakers is that stop smoking treatments work and they save lives. All smoking cessation treatments substantially improve smokers' chances of stopping. Varenicline is the most effective treatment for smoking cessation, and it's around 50% more effective than nicotine replacement therapy or bupropion. All smoking cessation treatments are safe. That's not to say that they don't have side effects. All medications have side effects, and it doesn't mean to say that there may be rare occasions in which something happens that would be cause for concern, so you have to be careful. But all smoking cessation treatments are safe, and concerns about serious neuropsychiatric side effects are unfounded. Thinking about how we can use these results to increase the rate at which smokers are being afforded the ability to use smoking cessation treatment and are motivated to do it. I've just presented data here for smoking cessation in England in 2015, and these are from the Smoking Toolkit study, which is a regular monthly survey which we run and have been running for around 10 years, and we get a sample of around 20,000 adults a year, of whom about 18% of those are smokers. What we see in England is that last year is that 33% of smokers made at least one quit attempt. However, only, even in the UK, where treatments are very heavily promoted, one would imagine, only 2.6% of these use both the prescription medication and the free behavioural support that's on offer. Only 10.8% used a prescription medication only, of whom 5.4% used Champix. The form of treatment that people, or support that people are mostly using, is an electronic cigarette, in which we found that 35.7% used an electronic cigarette. And almost half used no aid at all, and 13.5% used nicotine replacement therapy, which they just bought over the counter. And we found in large studies, and we consistently find this, that nicotine replacement therapy bought over the counter in England is not helping smokers to stop. So this is a wasted opportunity. So if you combine the 41.5 and the 13.5, you can see that more than half of smokers in England are not using an effective aid to cessation. This is a huge wasted opportunity. I'm just going to finish by talking about the one large observational study which you may have seen but perhaps not quite fully grasped what I think is the key message from it, to help to provide more information about this situation. This is a study that was published in Lancet Respiratory Medicine. I was one of the authors, and Daniel Kotz from Germany was the lead author on this study. It was a comparative observational study. The key design features were that it was a retrospective cohort study using GP records, and it compared varenicline, bupropion and nicotine replacement therapy. And the idea was to see whether either bupropion or varenicline showed a higher rate of a set of adverse events than nicotine replacement therapy, which is believed to be safe. As you can see here, the study was extremely large. It covered over 160,000 patients, of whom more than 50,000 had been prescribed varenicline. So if there were an effect to be seen, we ought to be able to see it with this kind of sample size. The outcomes were depression, diagnosed and treated, any mention in the notes at all of self-harm, or any of a range of cardiovascular events. In terms of the covariates, we looked at a range of possible covariates, socio-demographic ones, physical disease, alcohol misuse, previous depression and previous self-harm. The aim here, because this is an observational study, is to allow us maximum possible chance of being able to adjust statistically for any pre-existing differences between the groups. And the analyses were a Cox's proportional hazard, but we also undertook what's known as propensity score matching, in which you identify within the cohorts sub-cohorts that are matched pretty well precisely on a whole range of covariates which may influence the outcome. But the most important thing from my perspective of this study is that we modelled what would have to be the size of residual confounding to overturn the results. And these are the results. You can see that the confidence intervals are very, very narrow because it's such a large sample. And you'll see that in every case, in fact, with varenicline versus nicotine replacement therapy, the hazard ratio was actually lower for varenicline than it was for, the hazard ratio meant that varenicline had a lower rate than for nicotine replacement therapy for depression, self-harm and the ischemic heart disease. And with the propensity score matched cohorts, the results were almost identical. In other words, engaging in propensity score matching with these confounders made very, very little difference. But the key thing, as I mentioned, was this modelling of residual confounding. With that result, we were able to say what size of effect would the modelling, would the confounding have to be in order to make the results have gone the other way and for that actually to be an increased risk from varenicline. And what we found was that the unmeasured confounding would have to give a threefold increase in risk of self-harm, for example, threefold increase, which is higher than any variable has ever shown in our study. And it would have to be 8 times more prevalent in those prescribed varenicline than those, in both prescribed NRT than those prescribed varenicline to overturn the result. And none of the existing variables that we had anything like those statistics. So what that means, I think, is that the chances that the result would be overturned if we had been able to measure other potentially confounding variables are very, very slim indeed. So I would express these findings as showing that it's extremely unlikely that varenicline causes an increase in risk of depression, self-harm, or cardiovascular events. So we look overall at the EAGLE study. I think it provides the strongest evidence to date that varenicline and bupropion do not cause an increase in neuropsychiatric adverse events in smokers without a current or past psychiatric diagnosis. Very strong evidence. It doesn't rule out the possibility that varenicline and bupropion cause a small increase in mild to moderate neuropsychiatric events in stable psychiatric patients, but it makes it very unlikely that it's the cause of severe events of this kind. And it confirms that varenicline is more effective than smoking cessation than NRT transdermal patch or bupropion. For the COT study, it provides evidence against the hypothesis that varenicline increases the risk of depression, self-harm or cardiovascular events compared with nicotine replacement therapy in GP patients. So overall, the results are pretty much as we would have expected from all the other studies that have been done, the systematic reviews of randomized trials and the other comparative studies. And indeed, I have to say to my surprise, given the way that these things often work, the FDA Advisory Board voted in a majority, 10-9, to remove the black box warning, which is an unprecedented step on varenicline, despite the briefing from the Food and Drug Administration, which indicated that they didn't want to do this. And so we will know by the end of the year whether the black box warning has been removed. But in the meantime, the EMA, as you'll be aware, has removed the black triangle, which has a different meaning, obviously, in Europe as the black box warning in the United States. So when talking to stakeholders and policymakers and clinicians, clearly our job is to lower the bar to treatment, because the more people who use effective treatments to help them stop smoking, the more lives will be saved. That's my interest in this, and the numbers of lives involved are huge. And that's not even thinking about the chronic disability and the cost to the economy and so on that's affected by this. So I think the key thing really is to keep on with a very, very simple message that is now strongly supported by the evidence. If there were any concerns about safety, those can be put aside. They're safe. They are effective, and varenicline is more effective than nicotine replacement therapy and bupropion. And they are incredibly cheap as a life-saving measure. If you think about what happens when a smoker goes on to suffer from a smoking-related disease and the cost of the treatments there, or if you think about the costs of other medications that we use chronically to treat patients to prevent them getting diseases like blood pressure medications and so on, they are incredibly cheap and they're really easy to implement. It does require understanding and skill, but that's the kind of thing you'd expect any clinician to be trained how to do. And what's more, in Europe, as in other parts of the world, but particularly in Europe, the key professional organisations such as the European Respiratory Society are demanding this. This is not something which is coming from the industry as a way of just selling more drugs. This is something where the demand is coming from everyone who knows anything about smoking and smoking cessation. And the key message to end with is that failing to offer it to all smokers will cost lives, is costing lives, has cost lives, and this is something that needs to be remedied urgently.